Well, welcome everybody that is on. My name is Aaron Beverwyk. I'll shoot over Jeff in a second here, but we are proud to host our first ASNM Journal Club. This was kind of a project that the DI committee of ASNM developed and looked for some support from the education committee at ASNM. And Jeff and I and Brooke is here as well. She's not here today, but she'll be on in the future, are here to guide some of our younger IOM professionals and neurodiagnostic professionals in the art of looking at a journal, understanding a journal, dissecting a journal, confronting a journal. So today we wanted to present to you a really nice article about saphenous nerve SSCPs. I will give a small presentation kind of looking at, what would a student look at this paper like? And then we'll have a nice big discussion with everybody. So we'll have cameras on and microphones on to take a look at, what this paper postulated, what the results are, and then kind of look at the pros and cons of what the paper presented. So my background, I've been doing neuromonitoring for 20 years. I started off like a clinician like anybody else, and then over my career, I dove into the education component of it and been the director of education for three of the major private companies in the United States, along with major committee membership in ASNM and ASSET as well. So, Jeff?
Hey, good evening, everybody. Thanks for joining us. I always get excited about when ideas come to fruition. And I've been beating the drum for years about, we need to get together and do journal clubs and it's always hard to get things off the ground, but hopefully this will be our first foray into this type of interaction. As Adam said, what the goal is, and we're going to learn as we go along, but what the goal is, and we do this at our institution every Wednesday morning, and we assign a paper to a technologist and they present it, and I moderate it, and we go through it, and we ask questions, and we pimp people for answers, and it's the first and foremost, nothing about this is meant to be punitive. It's all about learning and to look at the limits of your knowledge, look to expand your knowledge, et cetera, et cetera. So, I mean, I love doing this. This is the fun part of our job. It's like I said, we do this every week, and it's great. My background, I've been an IOM for longer than probably some of you on the call have been born. I'm at UPMC. I've been there 33 years, and I do education, I do professional oversight, I do cases with technologists, I do things on my own, et cetera, et cetera. So this will be fun. So what we're going to ask you to do is we can see who's on here. So we're going to ask some questions, and we're going to see if people volunteer. And when you volunteer an answer or a thought or whatever, just unmute yourself, turn on your camera, and we'll talk about it. If we don't get a response, I'll call somebody out. Believe me, love doing that. Anybody who's ever been in my lectures knows that I love doing that. So I'll turn it back to Aaron, and we'll get rolling here.
Okay, great. So I'm going to share my screen and somebody say, yay, I see it. Starting off real quick. You guys see the article, correct? Oh, let's switch
Still
over.
blank.
What's that?
Still blank. Just a blank
All
screen.
right, let's see what we got. So move that away. There we go.
Okay, good. We're good.
Okay. Well, I just wanted to show it for a second, so we're going to switch over here. So this is the article that we're reviewing today and talking about. So optimizing the methodology of saphenous nerve somatosensory evoked potentials for monitoring upper lumbar roots and femoral nerve during lumbar spine surgery, a technical note. So as looking through this article, I wanted to give a simple PowerPoint presentation as if I were a student. Okay, so I kind of looked at it as what would a student want to say about this information? So let me switch over to my PowerPoint. Let me know when you guys can see it, and I'll just run through it as if I'm giving a journal presentation.
All good.
All right. Sorry, okay, still good, right?
Yep.
All right, it's going. Hold on one second. Presenter view is not going for me here.
Just stick with this.
I'm trying.
Oh,
It it keeps going back and forth. All right, Ariel, Kayla, any suggestions?
Um,
It keeps um
it's not
going back.
new.
Hold on one second. I'm gonna stop share and share again.
Yeah, that's what I would. Zoom is a little different. You have to, it'll only share like one screen at a time.
Gotcha. Okay, I'm gonna try the PowerPoint again, and then I will share again. All right, how we looking? Let's see if it'll connect.
good. And it's in presenter mode.
Okay, we're good?
We're good.
Okay. Okay, so we already talked about the journal to review. Okay, so introduction. So kind of when I looked at this was why did somebody write this journal article? And the reason behind it is the authors express that lumbar surgeries can range from, let's say, L1 down to S1. We know we can go, further than S1 as needed, but the traditional lower extremity SSCP coverage is often from posterior tibial or tibial nerve SSCPs. And anatomically, the nerve root coverage there is from the L4 to S3 range. So the article says, let's look at the optimization and assessment of saphenous nerve SSCPs, which is the sensory division of the femoral nerve, because these nerve roots cover L1 to L4-ish. So when they evaluated the saphenous nerve SSCPs, let's look at it as two different studies. They did distal versus proximal nerve stimulation in part one. And then part two was they looked at the SSCP head electrode recordings from three differing montages, purely from distal stimulation. Doing this, they looked at the amplitudes from saphenous nerve from the same patient and both legs. So they looked at proximal stimulation as well as distal stimulation. So every patient had, let's say 4 SSCPs. They had proximal left, proximal right, distal left, distal right. The second method or the second comparative was looking at the amplitudes from the 3 cortical montages from the same patient by proximal stimulation.
Distal.
I'm sorry, that should have said distal stimulation. You're absolutely right. Okay. First off, Jeff and I both agree this is an amazing, amazing figure. This figure right here that demonstrates the anatomy and the stimulation technique and placement for both the proximal stimulation and the distal stimulation of the saphenous nerve. I took this picture and I'm adding it to my lectures and education materials because it's a great picture.
Aaron, you don't mind if I jump in every now and then, do you?
Please go for it.
So great figure. Agree with Aaron. What I will tell you is that most, if not all, patients at the University of Pittsburgh Medical Center having lumbar surgery, their legs don't look like that. I mean, landmarks are really, really important, right? And that's one of the things the authors stress here is the ability to find, proximal versus distal landmarks. So, and in talking about the paper beforehand, one of the things that I said to Aaron is, I really like papers that are technique papers, and that's what this is, right? It's a technique paper. It's not an outcomes paper. They're not looking at how these patients did after surgery, et cetera, et cetera. So that's one thing that distinguishes this paper. But one of the things I like is it's something you can literally fold up, put in your pocket, take to the OR, look at the figure, and help it guide you where you put your electrodes. So I agree with Aaron. Just a really, really good figure that really expresses the optimization of these responses they found. Let me ask a question of everybody. So in their introduction or their methods, I think I forget what it was. Actually, it was their I always, when I read a paper, having done this for a long time, I always stop and pause when I don't understand somebody. What's the fibular nerve? Does anybody know what the fibular nerve is? They talk about stimulating the posterior tibial and the fibular nerve not being optimal for activating those higher roots that Aaron told us about that saphenous nerves do. But what's the fibular nerve?
The fibular nerve is another name for the peroneus nerve.
Common perineal. Very good. Excellent. That's right. That's exactly right. So what they're talking about is whether you're stimulating at the, at the medial malleolus for the tibial nerve or behind the head of the fibula, the perineal nerve. Neither of those gives you any coverage above L4. So excellent. Excellent. Good.
Thanks for jumping in, Jeff. Yes, please, anytime. And then the other figure is just a generalized montage placements for the second part of the study, looking at the head electrode placements, which we'll dive into when we look at the study and the results. Okay, so the methods, part one, pretty simplistic of what they looked at. So you have 104 saphenous nerve SPs from 52 different patients, so a left and right leg. Proximal nerve, as Jeff just pointed out, talked about the placement they utilized and looking at the picture as well. Proximal nerve stem is more looking at the vastus medialis and the sartorius muscles using anatomical landmarks. But as Jeff pointed out, one of the problems with this territory is the differing patient anatomy that we have, and looking at these different types of legs can be potentially difficult for proximal stimulation. Distal stimulation utilizing the surface pads on the skin surface between the tibia and the medial gastroc. They utilize stimulation techniques similar for both proximal and distal stim, anywhere from 40 to 50 milliamps of what they called theoretical supramax, which I'm sure Jeff will touch on later or now. 0.5 milliseconds, 0.7 hertz, 70 to 130 averages, and they used one montage for that. Responses were deemed quality if they had a repeatability and positive and negative peaks, P37 and 42. And they had a general anesthesia of Tiva and or half a mac of gas with propofol. Jeff, did you want to jump on these now or later on?
I'll just touch on the one. So,
Yeah.
one of the things I do when I review a paper is I like to look at some of the things that the authors say that I find to be provocative or interesting, and I look at the reference in the reference list that they use to support what they said. So the theoretical supermaximal stimulation of 40 to 50 milliamps, the reference they use is a paper from 1978. I don't completely agree that they know that they're super maximal. What's an easy way to know if you're super maximal when you're doing stimulation by looking at your evoked potential? Anybody, somebody. So if you're doing a median nerve SSEP, how do you know that your stimulation is super maximal?
Well, I think it's when you increase the intensity of the stimulus, the amplitude doesn't increase, stays the same.
Precisely, right. You develop an IO curve is what we used to call them when I was younger, and none of you were born again. So you look at increasing intensity and how the amplitude scales with intensity, increasing intensity. And when the amplitude no longer increases significantly, usually by 10 or 15, 20%, then you know you're super maximal. We're going to circle back to the stimulation intensities because, think about that in terms of body habitus and BMI that they touch on. And, just look down at your own leg, the difference in the circumference of your thigh versus the circumference of your calf, and think about stimulating them both at the same intensity. Do you think you're really, stimulating both at 40 to 50 milliamps? Do you think they're both equally super maximal? And we'll get to that.
Thanks, Jeff. Okay, part two. Very straightforward. 100 saphenous SP from 50 patients. Distal saphenous stimulation from 3 montages: CPZ to FC, CPZ to CCP, and then ICP to CCP. I'll touch on those later. interesting thing that it pointed out for me is really the only settings they listed were the filter settings for the SSCP cortical channels. And then they jumped right into some statistical analysis for the amplitude differences. They looked at a statistical analysis for the amplitude, and then eventually they broke it down by gender, obesity, diabetes, and inhalational agent use. So something that we'll touch on later on in the discussion component of this paper. Okay, results. Pretty straightforward. Distal stimulation had higher SSEP versus proximal stimulation. So when they looked at the nerves, 97% of the nerves tested from distal stim had the same or greater amplitude than proximal stim. The chart or the data they provided, Jeff and I both agreed, was a little difficult to comprehend. But if you look at distal on the bottom, proximal on the top, A is 73% of distals were larger amplitude than proximal. 12.5 were relatively the same. 11.5 showed a distal amplitude and an unmonitorable proximal amplitude, and only 3% of the nerves showed a larger amplitude response in proximal stem versus distal stem. So
I'll come down on a figure a little harder. It sucks.
yeah.
I hate not being able to look at a figure. First of all, I hate looking at a figure and having to read the figure legend. That's stupid because that's what the figure's for, right? The figure should be telling the story that the text is telling so you can reference the figure. This figure's confusing as hell. I mean, if you just look at this in isolation, I have no idea what it means. But anyway, the message certainly was delivered in the text of the paper. The figure, they could have left this out as far as I was concerned.
Yeah. And it's just old. To me, it's old data too. We have such nice, cleaner data nowadays than than that type of data there. Okay, part two results. CPZ to C to CCP had the highest amplitude.
Can we stop there?
Yeah.
Can we talk about basically them as two different studies and go over them as such?
Yeah, absolutely.
Okay, so does anybody have any comments, criticisms, raised eyebrows over these results or the veracity of these results? In other words, okay, I see what you showed here, but given how you described your methods, could it be this? Could it be that? Maybe it's this. Maybe it's that. Did anybody glean anything from the methodology of this paper that might weigh into how you interpret the legitimacy of this data? Okay. Let me ask the question differently, and we'll try and get to the answer to that question, the first question. Were there any significant differences in the methodologies with regards to how these nerves were stimulated?
I noticed that they didn't use the same type of electrode, which I kind of found was interesting.
Ah,
Right.
Cameron,
Thank you,
boom, boom,
Cameron.
boom, ding, ding, ding. That's right. So they used needles for proximal and sticky pads for distal. Okay, here comes a bonus question. Cameron, I'm gonna have you try and answer this one. What's the difference? If somebody said to you, well, how is that different? What's the difference if you use needles versus sticky pads? What would your answer be to that? Or anybody?
Well, my first inclination was just the impedance could be great. Like there was no evidence of like the difference in impedance between the two.
Okay, see now
Because
you're opening cans of worms. What do you mean by that?
well, like you have to prep to do sticky pads, right? And you are much further from the nerve to begin with when you place a skin electrode as opposed to when you stick a needle, you are more likely to get that much closer to the actual nerve or muscle that you're trying to do just from a standard. So,
Okay, good. So you're getting there. You're warm. So, but you were talking about impedances, right? But let's talk more about what you're saying right now. So the question is can you make any suppositions based on what we know in the efficiency with which we deliver current to a nerve based on using stickies versus needles?
Needles are far more efficient.
Okay. So
Okay,
let me play
go
devil's
ahead.
advocate
Good.
to that then, Cameron. Are you ready?
Sure.
Where were the needles? What part and where were the surface pads?
If I'm not mistaken, the distal needles were approximately 14 inches above the ankle bone.
Uh-huh.
Uh, uh, I believe, if I'm not mistaken. And then the uh, proximal were in the inner, you said sartorius muscle, I
Yep.
believe, near the what would that be? The medial uh lateralis muscle as a whole, which um I would I think I understand where your argument is purely going to be is you have far more for the needles of the proximal, you have to go further in to get to the nerve to begin with,
Correct.
while along the bone of the tibia, you have a much smaller area, and so you could make the argument that you have a less distance between your skin electrode and the nerve that you're seeking. But in today's society, you have people who have pretty thick calves and shin bones.
Easy there, Cameron.
Well, I agree, Cameron, and I'm not. I think initially you said needles distal, and then you said surface pads distal. So the surface pads were distal, and the needles were proximal. So, and recall, here's where I think Jeff is going. Okay, so needles were proximal, surface pads were distal, and the distal saphenous SSEPs provided higher amplitude responses in the majority of the cases. So let's just go with the surface pads were providing, I'm just making a general statement, higher amplitude responses. So where does that take us? Where does our thought process go from there? With this article and with neurophysiology. Anybody?
So what's the fundamental difference between a sticky pad electrode and a needle electrode in terms of the current density? How much current is being delivered over either the surface or around the needle electrode? Please, anybody guess? Just guess. So do you think sticky pads are
Okay,
high? What's
with
that?
a sticky pad, this is just a guess, is there's a lot more surface area, like it's covering more area versus a needle. So a
Yeah,
sticky
so
pad.
the more electrodes that's touching the patient, the higher the current density, right?
Yeah.
So the whole issue here, and Cam, I think you were touching on this very nicely, is that, why not do them both needles or both sticky pads? Because it really muddies the waters. It really does. It really does. And ironically, and I'm going to say this as a criticism of the paper, I think they do that on purpose so that they can extol the fact that sticky pads are cheaper than needles, and that's what they say. They actually come out and say that in the paper. And so I say, okay, well then do sticky pads on the proximal stim too, and show us the differences there,
Yeah.
because they might be the same, right? I don't know the answer. Does anybody know the answer to that?
I don't.
Nope. I don't know. So once again, I think you have to look at things as, are they comparing apples to apples or are they comparing apples to oranges? And I don't think it's necessarily it's Granny Smith the Honeycrisp. I think they're both apples, but I think they're different apples. Let me put it that way. Was that a bad way to put that
I got
analogy?
it.
But
It
yeah,
made
but
sense.
yeah, you know what I'm saying. And I just would have liked to have seen that. Despite that, I think their overall rationale is that because of BMI, because of the muscles, because of the circumference of the calf versus the circumference of the thigh, needles get you. I think they would argue that they were the same stimulation exposure, because needles got them closer to the nerve in the thigh because they go deeper, but the nerve is closer to the skin surface in the thigh, excuse me, in the calf. And so sticky pads were good. But I still think it raises some thoughts about, is that why there's a difference? And I don't know the answer. But always think about those things, right? Look at the methods and say, are they doing the same things?
Right.
Were we moving from methods onto something else?
No, we did results. So
Okay,
now it's just discussion. So we're still kind of talking about and
Okay.
dissecting and thinking about part one of this study,
Okay,
proximal
cool.
versus distal stimulation.
Great. So let's for a second talk about the subject that everybody hated as an undergraduate. Let's talk about statistics. So every time you read a paper, you should carefully review the statistics portion of the paper. And why should you do that? Because the author's results and ultimately conclusions are going to be based on the results of the statistical measure that they used in a particular study. So I know everybody read the paper carefully. What type of statistical measure did they use in this paper? Anybody? Somebody? It's in the paper. Not a trick question.
I think we caught them because it's not something that maybe anybody really thinks about when they're looking through the paper, Jeff. You know?
Oh,
What
you
was
got
the
to.
question again? Sorry.
What type of statistical measure did they use to present the conclusions of the results?
A mean and standard deviation.
The last paragraph in the methods and technical considerations portion of the paper. What did they use? If you didn't read it, I hope you have it in front of you. They used a two-tailed t-test. Who's heard of a two-tailed t-test?
I have, sadly.
Something you wanted to
Feel like I
forget.
said, sadly.
Yeah, something you wanted to forget forever for the rest of your life. So, so was that you, Cameron?
Yeah, it was.
So what's a two-tailed t-test? What are the two hypotheses that are tested? What are they called? Do you remember that? And if you don't, just say no.
Uh, you're basically, it's like you either have it or you don't have it.
Right. So there's a null hypothesis
And yes,
and an alternative hypothesis. And the null hypothesis says there's not going to be a difference between my two groups, right? And the alternative hypothesis is we're going to find some significant difference, right? So the nice part about doing a t-test for this particular study is they're just comparing two groups, right? And the null hypothesis is there's not going to be any differences. Their alternative hypothesis is there are. The other really nice thing about a two-tailed t-test is you don't need a lot of power. What does that mean? Your statistical measure doesn't need to be powered very high. What does that mean? The strength of your statistical measure doesn't need much power. Does anybody know what that means? It just means you don't need a lot of patients, right? You don't have to have a big N. And what was our N in this paper? 50 patients, right? And we're still talking about part one, 50 patients, right? So what dictates the veracity of a two-tailed t-test in terms of the number of patients? What's the most important thing, even if you only have 50 patients? Anybody want to guess?
You say that again in another way, Jeff. I know what you're saying. I just want to make
So
sure.
So if you only have 50 patients, what is it about those 50 patients that make a two-tailed t-test the right statistical measure? It's that the patients in both groups are evenly distributed, right? Which, for simply measuring proximal and distal amplitude, they are, right? 50 patients, 50 proximal, 50 distal, right? Without giving away another punchline to the paper, once they start talking about diabetes and start talking about BMI, I think there were only 11 patients with diabetes. And I would, it would be unimaginable to me that be a reasonable statistical measure in 11 patients to make the statement that, oh, that was statistically significant too. I would like to see those statistics, but always think about, I mean, listen, there's journals these days that will send back a paper with a bad review or reject a paper because your statistics weren't appropriate for your sample group. So you always have to think about that. Now, Cameron, to your point about sadly, you remember the two-tailed t-test? We send our stuff to a statistician because I don't want to do this stuff either. We say, here's what we did. Here's how many patients we have. What measures best for this group? But a two-tailed t-test is pretty straightforward. So legitimate statistical measure for 50 patients, equally distributed, looking at proximal versus distal. So legitimate. I would question the statement they make about, I think they said something like the statistical significance also held true for diabetes and BMI. And I'm like, 11 patients? I don't know how you did that. But anyway, all right. Eric, please. I digress, but I do that all the time.
Yeah, that's okay. I had a similar, or not similar, just another thing to point out, with the data, that was presented, maybe we can make a deduction that maybe distal stim it is an appropriate utilization for this based on the results given in this paper. What other component did they take a look at and then just kind of give a brief sentence or two about and then move on from that could actually be super beneficial in the operating room? What other aspect of this did they look at in this part of the study?
The BMI.
Not what I was looking for. What else did they measure? They measured something else.
Is it leg movement?
Yeah. And I know that my surgeons would be very interested in, all right, which one is a quality way to monitor and which one will impede my ability much, throughout the surgery much less. And what was their finding? It's probably not surprising.
The distal was better for having less movement in the leg compared to the proximal.
Absolutely, and which isn't surprising, right? So looking at the information that they gave us, the distal stimulation provided what we'll call a quality or more compatible amplitude throughout the amount of patients that they looked at, and the legs moved less, so the surgeons were less annoyed. So just another aspect if you're looking at what is an appropriate utilization of this information, just something else that you can put in your memory bank or discuss among your colleagues about utilization of this. So any 2 cents on that, Jeff?
No, agree 100%.
Yeah.
I did want to ask one quick question. How many people have experience in doing these, and how many people have experienced what these authors say their results are? Anybody do saphenous SSEPs? Or have seen them done? I know you're students or new to the field.
Once or twice. And we didn't get a response from the proximal one, just the distal.
Yeah.
But we use patches for both, no needles.
Yeah, that's our experience too, where we do these in the cases that we're asked to perform these. Always get better responses distally and always have a crap ton of leg movement with this proximal stim. Always, always, always. And if you think about it, it makes sense, right? These electrodes are on the surface or near the surface, if you will. And if you're depolarizing or stimulating any part of the vastus, the whole leg will move, as opposed to that distal stim where you're probably just gonna have some foot movement. It's like the difference between stimulating ATib and common perineal in a patient who's not paralyzed, right? ATib, the foot just taps, if you do common perineal, the whole leg jumps off the bed. So the more proximal you get with your stimulus, the more activation of muscles that are more likely to move the whole leg will be. So yeah, that is certainly our experience as well in these cases. So good, excellent.
All right, well, so let's review the results from part 2 of the head electrode placement, cortical leads. Similar, I'm sure Jeff will be very dissection of this data again, because again, very confusing, but the takeaway was CPZ to CCP provided the highest amplitude followed by CPZ to FC, and then the two CP3, CP4. Now, not necessarily surprising if you think about the neurophysiology and the parietal lobe and the sensory innervations. My question here would be for somebody who is newer to the field, did anybody get confused with these letters like CCP, ICP, things like that? Was that confusing to you at all? Because I found in my pathway that I wish more people touched on it a little bit more. Does anybody have any?
What do you mean? What do you mean the newer people to the field? I didn't even know
Yeah,
what the hell those were. I had to go
that's what
back
I
to
said.
them. I got to go back to the 1994 ACNS guidelines for montages
Yeah,
to know what the hell CCI was. I'm like,
yeah,
I mean, doesn't everybody use like CZ, FC, PZ, C3, C4?
yeah,
What the hell are all these letters?
yeah,
I had no idea what the hell they meant.
exactly.
I had to look them up. But then ironically, the figure of the head electrode placements were the clearest thing in the paper when it
Yeah,
came to
yeah, they were
derivations.
exactly. They were beautiful. So, does anybody want to touch base? Give us your 2 cents on, little c CP or little I CP. What are you seeing there?
Yeah,
Did
the
somebody?
figure mentioned that it was IPSI versus contralateral.
Okay, so you said IPSI versus contralateral, John. What does that mean? What define ipsilateral and contralateral? What does that mean?
Yeah, IPSA being that it would be on the same side and contra being opposed to it.
Perfect.
To
That's the
what?
definition of ipsilateral and contralateral. And Jeff took my punchline. To what? And that's the punchline. Ipsilateral, contralateral, to what? What does that mean? What are they ipsilateral and contralateral to?
To the side you're stimulating.
Yes, and that's the
Ah,
big
perfect.
kicker. That's the big kicker. So contralateral, so if I'm stimulating left saphenous nerve, CCP is a contralateral, so it's the electrode on the left. Ipsilateral would be, or sorry, electrode on the
Right.
right. Ipsilateral would be electrode on the left. Now, one thing I always teach is how many electrodes of choice do you have to pick from for CC or for contralateral, ipsilateral? How many electrodes do you have to pick from? If that makes sense. What are your possible answers? If I say CCP, CCCP, or ICP, what are your answers? They could either be this or that, right? What are your potential answers?
Are you just looking for like CP3 and CP4?
Yes, that's it.
Yeah.
That's it, right? Or whatever your organization is utilizing for the cortical responses on the left side and the right side. So the answers are CP3 or CP4, right? It's just which one is considered contralateral or ipsilateral. So very, very quality, amazing answer. Let's take it one step further because I just love when our students get these answers. If we're stimulating the left saphenous nerve, and we know anatomically that the pathway of the sensory nature, the afferent pathway, decussates and crosses over in the brainstem, why are we getting big responses from CPZ to CCP? Why is the contralateral one producing these great responses? What's your thought?
Is it because of where it's located on the homunculus?
Okay, and where is that?
On the inside of the hemisphere?
On the
So it's
inside?
projecting to the other side of the brain,
Okay,
or the other side of the skull.
medially or laterally?
Medial.
Okay, so it's projecting to the other side of the skull. Somebody dissect that statement.
I can't.
Right? Okay, so how about this? If we're looking at CPZ to CCP, which one is the active electrode? Which one picks up the response? CPZ to CCP.
They actually tell you in the paper.
Yeah. Which one is the active electrode? CPZ or CCP?
CPZ is the active and CCP is the reference electrode.
Okay. Yeah. So here's the thought though. Okay. I'm looking for a fun, my favorite neuromonitoring word. Okay. So CPZ is the active. Why is CCP not being considered the active? If we crossed over and we going to the contralateral electrode, why is CCP not considered the active electrode? What big neuromonitoring word am I looking for?
Is it paradoxical lateralization?
Oh, thank you, Samantha. That's my favorite neuromonitoring word. Paradoxical lateralization. Yes. So CPZ is the active because even though we're crossing over and synapsing in the contralateral brain, the dipole and the electric field point to the ipsilateral electrode. So the CCP is actually the best reference in this channel montage, and CPZ is there. So just, looking at this paper, taking a moment and throwing some neuromonitoring out there, but I think it could be confusing for a newer person to look at this and say, it's very confusing where they're getting it here and why are you using this one and that one, and it might take a little extra step of looking back through your education notes to look at that. So but not surprising that anything involving CPZ with the medial synapse of the lower extremity SCPs and the homunculus producing the highest quality response anatomically and neurophysiologically. So, Jeff, any 2 cents on any of this part 2 results?
No, it's interesting. When I first started in this field, we always used to do that lateralized response for lower extremity SSEPs, and then we sort of got away from it. And we do a midline PZ to FZ. We do a C3 to C4, cross hemispheric response. And we do a subcortical brainstem response. And we really got away from it. But, my recollection is there were times and in doing these recordings where that lateralized response was always the most robust response, despite the fact that you might think that a midline active and referential electrode might be the most robust because that's where, quote unquote, the dipole should be. But remember, because it's an interhemispheric generated response, it's not a dipole that goes from front to back. It goes from cortical region to cortical region. So, not surprising. I have a question for everybody though. So, and you, Aaron, too. So if you're doing monitoring, whether you're doing saphenous SSEPs, and I'm sure everyone's seen this. Let's make it easy. You're doing TIBs, and you've got all these channels, and one of the channels changes significantly in amplitude, and the others don't. What do you do? I know everybody's seen that because I see it every day. What do you do? What are you thinking? What could cause that? Is that a problem? Do you tell the surgeon? Do you just sit on it? You don't worry about it. Do you pick a channel to focus on before you start? How do you handle that?
Well, every channel is supposed to be like a different part of the brain, like cortical, transcortical, subcortical, peripheral. So if my peripheral goes away, it's maybe thanks to ischemia, and you gotta reposition.
I'm sorry, Wendy, I wasn't clear, and I apologize. And you're correct in your answer. My question was about just cortical recordings.
Okay.
So if you're doing PZ to FC, you're doing a midline recording and you're doing a cross-hemispheric recording, and one of those channels changes in amplitude, but the other one doesn't, what do you think?
Well, it depends how much percentage it went down, if it's significant.
Okay, let's say it's significant in one channel, not the other.
Like just one channel on the same side?
Sure.
Sure. What do I do? I probably tell the surgeon because
Okay.
I've had cases where just one channel goes down and the patient's having like a stroke.
Okay. Okay,
Okay.
so you just made an interesting point.
Oh,
So I think it depends on whether it's spine surgery or brain surgery.
Correct.
well, I was thinking on brain surgery.
I know, right? Exactly. That's a really good point. But in spine surgery, can you do anything in the spine iatrogenically that affects the dipole orientation in one channel versus the other that is of significance? Do you think? I don't know the answer for sure.
Oh, if you don't know the answer.
Sorry,
You
Wendy.
threw me on.
No, probably not.
I
So,
really don't know.
yeah.
Yeah, either do I. I can tell you that, as you suggested, you've done a couple cases in brain cases where it makes a difference. I've never seen it make a difference in the spine. Never,
Okay.
ever, ever.
So, Jeff, you're
And it
saying
happens.
if you have two channels, let's call them cortical channels, and one goes wonky and the other one's there, are you feeling comfortable with the spine case?
Every time.
Perfect. Okay. So you just led into my point, and they actually touched on this.
They do. Right. I know where you're going to
Which
go.
is what? What is the takeaway on spine surgery from what Jeff just stated with looking at these part two results? What should you be doing with SSEPs based on this information?
Well, what I take from this is having more than one channel for
Ding, ding,
every
ding,
nerve.
ding, ding, ding.
Right.
If you have I have 32 channel systems that I have programmed for different cortical channels that we could have available. Okay. Because we always want that backup, for spine cases, that repeatability, the ability to say, hey, this one's down, but this one's stable. So we know we're getting from tibial nerve up to the brain through the spine.
Right.
And that's exactly what they touched on it briefly, but they did touch on it, that utilization of more than one cortical channel is advantageous for sensory monitoring.
And the authors only use the word dipole once in the paper. And what's it in reference to? Does anybody remember that sentence? Blank can cause a shift in the dipole, I think was the sentence. And what can do that? Anesthesia.
Anesthesia.
That's how these things change like that. It has nothing to do with the spine. It's really about the anesthesia. So one of the things that's interesting in the paper that Aaron and I spoke about was, if you are concerned about anesthetic effects, which we all are in every case we do, and it's a spine case, and these are spine cases, what data do the authors not present to allow us to compare proximal versus distal stimulation? What don't we see? We don't see the subcortical channels. We don't see anything from the brainstem. Nothing. So maybe they don't change. Maybe there's no difference at all in those. So who cares where you stimulate? Right? All they're showing us is cortical channels. That's it. That's it. So I would be really interested in seeing the subcorticals in these cases and see what they look like, particularly given their figure 5. I think it's their last figure. Because hot damn, those are the best looking saphenous SSEPs I've ever seen in my life.
I would love to see those.
So I'd love to see those, what the subcortical looks like with a cortical recording like that. But so I hope everybody's sort of getting the idea of when Aaron and I review a manuscript or prepare a manuscript or think about collecting data in the operating room with the goal of maybe publishing it. How you have to think about all the things that go into your paper, starting with your aim, then your introduction, then your methods, and the methods contain X, Y, and Z. So, reminds me of another thing. So, what's one of the key? So there are what are called reporting guidelines out there for different things in the field, like EEG reporting guidelines, delirium reporting guidelines, and every paper that's published should have certain things in it for it to be considered meeting criteria for reporting guideline. So has you guys have read IOM papers before, we've read other papers before. So what don't the authors talk about in this case, in this particular paper, in the method section, that without talking about it could create bias? And we're gonna talk about that word in a second, that could create bias. Has everybody ever heard the term inclusion and exclusion criteria? So it never says whether they did 50 consecutive patients. It never says whether they pick and chose the patients who were in one group versus another group. More importantly, and Aaron, I don't want to steal this thunder, but you can touch on it. I'll say it and you can talk about it, is they never talk about the neurological status of the patients and how they compare them across patients. So if you have a patient with pre-existing quadriceps weakness, do you think the proximal is going to be worse than the distal? Perhaps so, depending on what that stimulus is actually giving you. Is it really depolarizing the saphenous nerve as well as creating what? A dermatomal stimulation of the L4, L5 roots. So inclusion and exclusion criteria is something you should always look for in a paper in the methods. And in the results section, this paper also does not have it. Does anybody know what should be in the last section of the results? I'm going to take a shot at that. What are the limitations of the study? Every paper published has its limitations. So what's one glaring limitation of this study? And it's almost every IOM study, but what's one glaring limitation that creates bias?
The sample size?
Sample size is actually okay because based on the statistical methods they use. It's retrospective. It's not right. So it doesn't create class 1 or class 2 data. So that's a limitation just by definition. But because it's retrospective, you are relying on the things that were reported or written down or annotated during the case, et cetera, and you have to go back and look at medical records to get that information, yours and others. So that's always a limitation of a study. I say one of the other limitations was being able to make come to conclusions with regards to diabetes and BMI based on the small number of patients who had it, right? Yeah. Clearly that's a limitation, but it wasn't called out. So just so when you read a paper, look for those things, right? And if they're not there, that doesn't disqualify the paper from being a good one, doesn't make it a bad one. It doesn't mean it shouldn't be published, but it should have you thinking about the things that you would like to see in the paper that may not be there, or things you'd like to have the authors talk about that they didn't. Points to ponder.
Well, we touched on them as we went through. So we were talking about, why would we care about L1 to L4 nerve roots if we have, let's say, PT on most cases, and they touched on the nerve root coverage of L4 to S3. We talked about ICP and CCP. We talked about other aspect of stimulation, which was the movement. And then there was diabetes mentioned, but as Jeff said, they just kept saying the word diabetes, but not actually, discussing that with the data. I think outside of one patient, they brought that up, and one of the people who didn't have good distal stimulation, and that was it. But as Jeff said, it might have been a limitation because they didn't talk about it enough or bring that in. And then Jeff talked a lot about this, the journal analysis of, statistical analysis. What is standard deviation and p-values? What is missing from their data analysis? And then Jeff just touched on these ones, the limitations and what factors were not discussed in the data analysis. So looking through this journal, and then I think I want to open up to questions, final couple minutes of questions for Jeff and I. But here's a great takeaway, right? Saphenous SSCP is just a nice quality replacement for the posterior tibial nerve SSCP in a lumbar surgery. Do we agree with that? They showed that saphenous nerve gave us good quality responses. We should probably start utilizing that instead of posterior tibial nerve.
Yes and no. It depends on what roots the surgeon is gonna work on.
Yeah, exactly.
If it's gonna work
Okay.
in sacral, it's not gonna be of any
Okay,
use.
let's say it's a L1 to S1 fusion.
I'll do both.
Oh, thank you.
Perfect.
And that's a great takeaway. And that's kind of the initial takeaway. No, if it is a quality nerve to add to your multimodality monitoring, they talked about the limitations a little bit of EMG itself and PTN and nerve root coverage and lower extremity motor evoked potentials. All these things put together give us a much better view of the patient, the neurophysiology, and the information that we're trying to assess. So, even with the limitations of this study, anatomically, we know that the saphenous nerve is L1 to L4, and if the surgery is within that range, adding saphenous nerve SSCP to your modality selection is a quality idea for the coverage of the nerves being presented. Now, which stimulation technique, which cortical montage coverage, can be deemed, something that your company and your group needs to look at. But this paper, I would say, anatomically, Jeff and I probably agree that it makes sense of what they presented. It's just their presentation of the data seemed like there was some territories that could be improved there. But anatomically, Jeff, we agree this probably makes sense, right? For L1 to
Yeah, and
L4,
remember,
saphenous nerve is a good idea, right?
yeah, and remember how the saphenous nerve evoked potentials were born, how they got life, and that was from lateral surgery, where in the lower cage placements, specifically L4-5, the femoral nerve traverses that disc space, and there was a high degree of femoral nerve quadriceps weakness, femoral nerve injury after these procedures because of the necessity to really retract back that nerve root at L4-5. And the problem was SSEPs weren't measuring that at all. And before the advent of the paper that Riley published and Brian Millen that showed that the MEPs, the quadriceps MEPs, were very sensitive. The saphenous was the one alternative, and Justin Silverstein was, I believe, the first one to describe the technique. And then he later, and Dr. Journet's group from the Netherlands, actually showed outcomes data as it relates to changes in the saphenous nerve SSEP and L4 nerve root, femoral nerve root retraction during those procedures. That being said, as Aaron points out, if you're doing an L1 to S1 fusion, your tibial nerve SSEPs ain't telling you squat above L4, nothing at all. The other thing I'll tell you, and they make reference to this paper, I think twice in this paper, is everybody should read that Rayner paper from 2016. Free run lower extremity EMG in these cases is freaking useless. Useless. They did 12,000 patients over 25 years and showed that it doesn't help with almost anything. It's just so highly insensitive and non-specific. It's unbelievable. You really have to be doing it. Number one, you have to be doing an evoked potential. Number two, you have to be doing an evoked sensory potential that's referable to the level at which you're working, or you have to be doing a motor evoked potential referable to what level you're working at. So don't, I'm sure everybody works with a lot of surgeons will say, yeah, I want SSEPs and lower extremity EMG, and probably not the best idea. And educating the surgeons with the literature is the best way to help them along and understand that.
We have a couple minutes just to field any questions or comments from anybody while Jeff and I are on. Anybody have anything they wanted to point out, learn more about, discuss while you got us both here?
Yeah, I had a question when I read the article. Do you guys recommend setting up the peripheral channel as well? Or just the cortical ones?
Oh, Aaron, go ahead.
The
I know what you're going to say.
peripheral channel for
For the saphenous.
like pop fossa.
Like CB5?
Oh, the subcortical.
Well, yeah.
Yeah, we call it absolutely.
In every case, yeah.
Yeah,
Yeah, why not?
Jeff just touched on it. Yep. I mean, it's just another component to the data that's useful. And aesthetically, it's very useful, looking at cortical reduction versus subcortical changes. So absolutely. I mean, on every case that we set up with SSEPs, you are at minimum we have 2 cortical channels and a subcortical channel. And then throwing in the peripherals is nothing but helpful as well, kind of depending on the surgery. So.
Well, it's introspective, that question, right? Because it does really tell us about the fact that somebody might read this paper and walk away and say, I only need to do corticals in these cases.
Yeah.
Because that's all they talk about, and they don't mention anything else.
Yeah.
And so that is as far as I'm concerned, that is a potential shortcoming of this paper, that they don't even mention the fact that should also be done. So Wendy, good call there, right? Because all they talk about is cortical recordings, and then they talk about anesthesia affecting cortical recordings, et cetera, et cetera. So good call.
Okay. Any other questions? Well, let's say we have 2 minutes. How's that? I know it's a weeknight and everybody's been busy and working. It's late.
Jeff, could you say the name of that 2016 Rainier paper again? I tried finding it. It didn't pop up.
It's in Spine. It's Raynor, Raynor. The second author was Ann Padberg. I'm trying to remember who the last author was. I think Lohman was the last author. I think it was in Spine in 2016. It's 12,000 patients, 25-year experience with EMG.
Oh, I found it. Thank
so
you.
that was if you look at the article, it's number 16 on the article in the references.
Yeah, I didn't remember that. Sorry. Yeah. So how about, if nobody has any questions, how about comments? What do you think about the format, how we did it? Because what we were thinking about doing moving forward was actually assigning an article to an individual or individuals who were signed up for the next journal club, and have them basically do what Aaron just did. And that's basically present it to the group. And then Aaron and I and Brooke, when she's back, sort of moderate that. But what we'd like to do is not only teach you how to read the article, but also how to present the article in a setting where you're teaching other people. So let's start with, was this helpful for everybody tonight? Or was it a waste of your time? Nobody say it was a waste of your time, please.
It's our first one, so go for it.
But yeah, I mean, helpful, format okay. What do you guys think?
I personally enjoyed it. It allowed me to have an opportunity to read something that I wouldn't have necessarily read on my own time. Mm-hmm. And as like Jeff, I'm in my clinical training right now. So having that exposure to different research that again, I wouldn't read on my own, I thought was good. And being able to discuss it and see the spots where I understood versus where I didn't understand something, and getting that clarification. I think that this helped me a lot.
Plus, you have to deal with me every day in the OR, which is also great.
It's not too bad.
kudos to you. Emma is one of our undergraduate bachelor students in neuroscience, getting her IOM certification, if you will. So she's doing her clinicals with us at UPMC. But thanks, Em.
I mean, I agree. I think you should try and read as much as you can. It's only going to make you that much better and that more. It's thought provoking. I love LinkedIn. because especially if you just start going on with the neuromonitoring people on LinkedIn, like Jeff and Justin Silverstein, just watching them post the papers, or even, you'll find surgeons posting videos and things like that. It's just another means of finding good information. And then you'll see, Jeff will jump on and make comments, and I'll read through what his comments are in the article, and what other of the educators in neuromonitoring, like to say about this specific article or that specific, case that somebody talks about. I every once in a while, when I get a good case, I just throw it on there and be like, hey, everybody, this happened to us. I was just talking about Jeff right before we got on, and just see what people say, what other insight people have into this type of scenario. So, as you're going through your career, if you get stuff like that, if you just, I had a case and it just didn't make sense, you make sure you talk about it. Don't just sit on it and say, I'll just move on to the next thing. I've been doing this, and I know Jeff and I have had this discussion. I've been doing this for 20 years, and I still learn things all the time. All the time. That I'm like, hey, wow, I wish I'd been doing that 15 years ago. That'd have been when I was doing Scully cases day in and day out. That would have been great to know, or something like that. So.
Yeah, and I think the point about it making sense is important, because what I can tell you for sure is things don't always make sense, right? This is a gestalt field. This is this is truly the practice of medicine for that reason, right? There is no recipe book. There is no right and wrong. We have alarm criteria that are there as not as a mandate, but as a guide. And what I always teach, and I always say, we always up-educate the technologists, right? I want them to be thinking like I think in the operating room. And the thing about it is that while you may not always know what's happening, you should always have an explanation. And I know that sounds weird, but it's true, right? Because what you're doing ultimately in these cases is you should get to the point, and many of you are in your training, you should get to the point where you're running an internal algorithm in your head about the things that could be resulting in the change that you're seeing. And despite the fact that I'm not qualified to do that, blah blah blah, it's bullshit. Everybody should be able to do that. And the development of a differential diagnosis, when you look at a change in the data, and we touched on it tonight. I think Wendy touched on it, Nicole touched on it. It's like, well, it all depends on whether it's a cortical change and a subcortical change, or both, or just one or not the other. In a spine case, right? In your head that if it's a cortical change and not a subcortical change, then your reference goes to anesthesia, blood pressure, all those kinds of things, and not necessarily something they did in the spine. Yep. And that's really where you want to get. And you'll get to that place by, number one, doing cases, and number two, reading the literature, right? And understanding the literature based on how people thought about it and what they did. And before this was done and published, they had to sit down and write a research protocol. How are we going to do this? And what's going to make the most sense? And I always tell people to write research protocols like a reviewer for a journal is gonna read it and test you on it based on the how good or bad the protocol was to begin with. And we punched some holes in this paper, but you know what? It's a good paper. And quite frankly, the Journal of Clinical Modern Computing is a really good journal. It has a high impact score. It's not easy to publish in this journal. So despite the fact that we found some shortcomings, I think it deserved to be published, and I think it's in a good journal. So, understanding those things, and, fortunately, I know everybody younger than me, which is everybody on this call, is definitely on social media these days. And there is just a tremendous amount of information on social media. LinkedIn, Twitter, you follow the right people, you follow the right surgeons, you follow the right stuff. People make references to papers. I know if I see somebody reference a paper on LinkedIn, I put the link on there so people can go to PubMed and click on it and go look at the paper. Yep. If you ever have a question about a paper, about a technique, and I was going to have Ariel afterwards give everybody my email address. Yeah. Email me. I answer. I'm crazy. My wife's in the other room. I answer emails in the middle of the night. So if you ever want, hey, Balzer, do you have this paper on X, Y, and Z? I'm like, sure, I'll send it to you in the morning. I can do that too. And the other thing I would invite you to do is nobody wants to do a whole lot of talking, and I understand that, but you'll get Aaron and I's email addresses, and please give us feedback about what we ask you tonight. Did you like it? How do you think it might be better? How can we do better? Even suggestions for reviewing a paper. Send us paper suggestions. Would love to hear about it because anything the first time can only be made better.
Yep. So Ariel and Kayla, can you try and send out the emails for three of us / just a small survey about the process so we can make it better. And then we'll give our little ASNM plug. It's that time of year. Our annual conference is next month in Denver. We'll all be there. If by chance you're going as a student, please come up and introduce yourself and say hi to us. And I firmly, highly suggest joining ASNM and being there for the information, trying to come to the conference and learn from the presentations that are being given. So really appreciate everybody coming on. I hope this was great. This was our first one. Jeff and I and Kayla and Ari were super excited. Brooke's excited to be here for the next one. So be on the lookout. After we dissect this one and get it ready, we'll put out the next one probably in the next quarter of 2025.
Thank you, guys.
Thanks, everybody.
Thanks, everybody. Have a great
Thank you.
evening.
Thank you.
Thank
Have
you.